Welcome, everyone. Thank you for joining us. Our webinar today is entitled, Are You Tired of Being Tired? Our guest speaker is Dr. Filomena Trindade. My name is Lenore Powell. I am a medical education specialist in the Atlanta's branch of Genova. I am serving as your moderator for today's webinar. Dr. Filomena Trindade is a teacher, author, and international sought-after lecturer in functional medicine. She is faculty at the Fellowship Master's Program in Metabolic Medicine at Metabolic Medical Institute, MMI. In addition, she's also faculty at Institute for Functional Medicine, IFM, and after obtaining her BA degree in biology, she went on to finish a master's in public health in the area of environmental health and epidemiology before starting medical school. She graduated first in her class in family practice from the University of California Davis School of Medicine, and she did her residency training in family practice at the UC San Francisco Santa Rosa program. She has been in clinical practice for over 22 years. Before starting her own private practice in 2004 in functional medicine, she was the medical director of a nonprofit organization that catered to the underserved. Her work has been published in Townsend Letter, Guide to Anti-Aging and Regenerative Medicine, Saúde Actual, and the Border Health Journal. She is currently very active in developing teaching programs in functional medicine in the US, Latin America, and Europe. Keep up with her activities at www.drtrindade.com. One of the most common questions asked during the webinar is about the availability of the presentation and the slide deck. These materials will be available on our website within a week of the webinar. If you are interested in having these resources, please click the Clinicians tab on the homepage where you will find access to our webinars under Medical Education. Or you can also log into your LiveGDX account to find these webinars. And if you don't have a LiveGDX account, please click on the Getting Started link on our homepage and follow instructions to set up an account. I'm going to transition and turn over the role of presenter to Dr. Trindade.
So my role for you today is to really look at a little bit of a review of the HPA axis, but also with respect to CAR, the cortisol awakening response, because I feel that that's an area where we haven't integrated it in our practices pretty much, even though I thought I was, but wasn't doing it correctly, mostly because I was having patients do their first collection within half hour of waking because I really wanted to see what that cortisol peak was like. But what I didn't know is that you need to know the baseline. You need to know what it is right when someone wakes up and then 30 minutes later to really get that response, to really know, how are the adrenals responding and is there resiliency? So I think that it's really important that we incorporate that into our adrenal panel, if you will, and then to review a little bit of, how does the cortisol awakening response vary with respect to our sort of normal diurnal cortisol testing that we've been doing, because we know that the hypothalamic pituitary adrenal axis is principally controlled through corticotropin releasing hormone secretion from the hypothalamus, but arginine vasopressin can also act synergistically with CRH to stimulate ACTH, or adrenal corticotropin hormone synthesis and secretion from the anterior pituitary. And this is really important that we understand sort of the diurnal variation of cortisol, if you will, but also realize that this sort of hormonal cascade is really controlled by secretion and synchrony of both CRH and AVP. And during periods of stress, they're both secreted in a pulsatile manner, but your AVP can stimulate your cortisol production, and it's not under the normal feedback control that you usually see when it's done when cortisol is released through ACTH. So it's really important to sort of take that into account and to realize how can then we apply in the cortisol awakening response to this, and how can it help us with our patients. So we know that sort of your normal diurnal cortisol testing is, or the graph, if you will, it peaks in the morning and then decreases pretty sharply until about noon, and then slower during the day, and reaching the lowest at night. And when it comes to our ability to adapt to stress, or what does stress then do to our cortisol production, we can go back to the studies of Hans Selye, where he described the general adaptation syndrome being composed of 3 different stages. Your stage 1, or your arousal phase, where you can have a rapid increases in catecholamines, as well as a slower increase in corticosteroids, or your stress steroids, or cortisol basically. And what he then called the adaptation phase, where you may have a sustained increased levels of corticosteroids, but you start to see an effect on physiology. And then stage 3, where you have more degenerative diseases that are sort of characterized by the adverse effects of these alarm molecules and these corticosteroids. So if we then try and apply this to the clinical setting, and what would we see on our laboratory values, basically with stage 1, your alarm phase, it's where both cortisol and DHEA can increase, but it's depending on when you are trying this with respect to the progression of the patient, you may have elevated cortisol, but DHEA could be elevated. It may also still be normal. Unlike in stage 2, where cortisol can be high, but DHEA starts to decrease. So it may still be in the normal range, but low in that reference range, depending on where you're catching the patient. Because remember, we are catching the patient at one point in time. But in general, stage 2, DHEA starts to decrease. So either it's low or, sort of very low normal. And in stage 3, being your exhaustion phase, or your late decompensation, where both your DHEA and cortisol will be low. So what is the cortisol awakening response then? Well, it's really that increase in about 50% of cortisol level that occurs around 30 minutes after awakening. It can be 30 to 45 minutes, but mostly it's about 30 minutes. And then, of course, you still have your gradual decline of cortisol throughout the day, reaching your nadir in the afternoon or in the evening, as I mentioned. But remember that there can be inter-individual variability in both the cortisol profile and the cortisol awakening response. But that cortisol awakening response in any given individual is really consistent, as long as most of the confounding variables are taken into account, such as time of waking, sex, age, etc. Now, the cortisol awakening response was first established by Pressner in 1997. There's lots of studies that have suggested that it is a really important correlation to take into account when you're looking at someone's adrenal stress profile. So then, in other words, you want to look at the cortisol throughout the day, but it is especially important to look at the cortisol awakening response. And to me, I find that particularly important because you can tell more about the resiliency of someone and what's going on in their adrenals when you include the cortisol awakening response together with your usual 4-point salivary testing, which you now are doing, 2 extra points. So it is easily incorporated. It's just a little extra step when patients are collecting their saliva tests, or their saliva samples, I should say. But I feel it can tell us a lot in terms of determining, how resilient is this patient, because sometimes you may see changes in the cortisol awakening response before you see it in the cortisol levels throughout the day. So just to get an idea, let's look at what is the cortisol awakening response. That's the largest gray box on the slide, and that is basically the peak in cortisol within the 30 minutes after waking. And then the cortisol throughout the day decreases. But remember that, if you look at this over 24 hours, the cortisol then is going to start increasing while we're asleep. I always say that a picture is worth 1,000 words. And I think it's important that we realize this isn't it's a diurnal variation, but it's sort of in this 24-hour period, even though we often look at it during the waking time. It's important to keep track of what is it really happening, the rest of the hours of the day. This becomes especially important in patients who may do night shift work, where the cortisol, their cortisol pattern may be switched. So let's look at a couple different scenarios of how you would incorporate the cortisol awakening response and how it might make a difference in someone. So, for example, in this patient where you see the cortisol awakening response had a large increase after waking. You usually want to see at least a 50% increase, as I mentioned, and this is often, it's expressed as a percent. And in this case, for example, there was a 128% increase. If you just looked at the cortisol curve, this person has elevated cortisol right throughout the day, and the DHEA is still in the normal range, although it's in the low normal, as you can see. And you would be able to incorporate the cortisol awakening response by saying, well, this person's still able to mount that response. Although they're in stage 1 and maybe tending towards early stage 2, they are definitely able to mount that cortisol awakening response. Let's look at in a second scenario. So scenario number 2, you see that the cortisol awakening response is still greater than 50% of expected, right? It's 128. But when you look at the cortisol curve, it is still high, but lower than the previous example that we just saw. But when you look at the DHEA is now low. So if you go back to scenario number 1, this would be stage 1 adrenal dysfunction, and you see that they're still able to mount the cortisol awakening response. In this case, this person's in stage 2, but again, they're still early stage 2, I should say, but they're still able to mount that cortisol awakening response. And as you can see with the DHEA, for example. Now, let's look at a different scenario. In this case, you have what looks like a completely normal cortisol curve, right? Because at each point it is within normal limits. That DHEA is still within the normal range, but look at the increase after waking. It's 55% of expected, and we want 50 or higher. So still in the normal range, but low normal. So this is someone that even though the cortisol peak looks normal, you would start to be concerned whether or not they have sufficient resiliency, or maybe they are slowly or quickly progressing into a more deficient state of adrenal dysfunction. And as you can see, this is just another way to graph it so you can actually get a better look at what the cortisol awakening response is. And of course, you can look even further, and we can look at the DHEA cortisol ratio as well. Now let's look at scenario number 4, where you see that the cortisol awakening response is abnormal, so it's 15% of expected, and we want it to be higher than 50%. But when you look at the DHEA is normal, but the morning cortisol is starting to decrease. So the morning cortisol is not normal. The DHEA is still normal. So this is someone that I call impending doom, because not only are they not able to keep their morning cortisol normal, they cannot get a normal cortisol awakening response. So there's low cortisol reserve, even though, or there's low adrenal reserve, I should say, even though the DHEA is normal. So this is someone who either has had an acute infection or some kind of an acute toxic exposure or an acute stressor that is sort of shifting them over. And these are the patients that when I look at, I want to know, okay, what's happened, and act quickly, because we know that the body tries to maintain normalcy as much as possible. So it wants to have the normal cortisol curve where the cortisol is highest in the morning. Whenever you see a dip in that early cortisol, then you want to try and figure out why and try to reverse it as quickly as possible. In other words, find what that trigger is and deal with it as quickly as we possibly can. This type of a cortisol response I often see with patients who are sort of on getting into that autoimmune spectrum. They may not have an autoimmune disease, but they've developed antibodies, for example, or there's been some kind of an acute either infection or toxic exposure, some kind of an acute incident. And of course, you can look at the different scenarios, with the different graphs within a scenario, that you can get better look at what is the DHEA and what's going on with the cortisol awakening response. So then let's just look at a little bit more in terms of how can we use this and how can it be useful to us in our clinical practices. So let's take a nice deep breath. Imagine, breathtaking view. This is one of my favorite places on earth, in my island, in St. George in the Azores Islands. And let's move on. Do you guys know that our brain can really only maintain focus for about 20 minutes, and then it starts to kind of wander? So I think it's important that even before the 20 minutes arise, that we kind of do something to shift our left brain, right brain action so that we can maintain focus, if you will. So let's look at, can we really use cortisol awakening response? Is it studied? Is there sufficient literature support for it? And the fact is, yes, there is. The stability and the reliability of the cortisol awakening response has really been studied and has been found, to be reliable. In other words, this is a marker that we can use that is not only reliable, but also we're able to repeat it with consistency. And so we can easily apply this then to our sort of your normal testing that you already do for the adrenal dysfunction or the adrenal function in general. And we know that in most people, or at least if they're healthy, the act of awakening is what's associated with that burst of cortisol. That's called the cortisol awakening response. And so it's really that sort of sharp increase over 50% from baseline being right as you wake up, of the cortisol level. And it is reliable, and you can use it to sort of monitor or add it in addition to your 4-point salivary cortisol testing to really help and assess where your patients are at any individual point in time. And the most important thing, though, is that the way in which you collect is extremely important. So what this study was showing was that the accurate cortisol awakening response measures can only be determined when you have strict adherence to the commencement of salivary sampling following awakening. So in other words, we have to educate our patients to follow exactly what is indicated. So you collect it first, right exactly upon awakening, and then 30 minutes later. Now, how do we then figure out what has caused an abnormal cortisol awakening response, and as well as any adrenal dysfunction? And if you know, as with everything, I have sort of my own protocols, or I've developed my own little approaches to things that I find has really helped me, but has really sort of put together a lot of functional medicine principles, and then try and expand it on it to apply to the clinical setting. So this is my list for potential causes of alteration of the cortisol awakening response and adrenal dysfunction. And at the top of the list, I have traumatic emotional events, because we know that can set you up for HPA axis dysfunction. And these can be stress at work, it could be early life stressors, sometimes even things that have happened in the womb. And this could be emotional, physical, sexual abuse, verbal abuse. Anything can set up that or set up for that dysfunction of the HPA axis. So it's really important that we take that into account and that we discuss this with our patients. And it's one of the reasons why I put that at the top of my list. And then things like a physical trauma, right? To the body, stress is stress is stress. It can be physical, it can be emotional, it can be spiritual, psychological. It is a stressor. So you want to consider that as well. But chronic sleep deprivation is one that has, gross effects, and that can happen rather quickly. So you want to make sure we take that into account. But also things like infections and even dysbiosis or changes in the gut microbiome. Aging, we know, because with aging, cortisol goes up. Any inflammatory disease, toxins, but also an acute physical illness. But don't forget about your EMFs, your dirty electricity, and how that can impact our health, the health of our cells, and the adrenals as well. But nutritional insufficiencies can be a stressor, as well as a food intolerance or a sensitivity. Also changes in our detoxification pathways are altered by our transformation. But also hormone imbalances and other hormones can be the cause. And then don't forget that you may also have genetic single nucleotide polymorphisms that can affect that as well. Now, we know that one of the reasons why I put sort of stress at the top of the list is because we have lots and lots of literature on this. The ACEs questionnaires, and even before the ACEs were done, and subsequently to the ACEs questionnaire, we have more and more literature showing that even low levels of childhood adversity can predispose individuals to have this sort of dysregulated HPA axis, later on in life. So you definitely want to look at that as a potential cause in our patients. And then what about when we're talking about like subjective memory changes. We know that sometimes you can see that before you see cognitive changes objectively. So in other words, there's significant associations between someone's subjective memory complaints and diurnal measures of cortisol, particularly in elderly individuals. So this suggests that you may be able to see this with alterations in the cortisol awakening response as well as the cortisol curve in patients who have subjective memory changes but that are not yet detectable on neuropsychological testing. So extremely, extremely important. And more, we've had lots of literature showing that, someone with subjective memory complaints or sort of your subjective cognitive decline is highly, highly significant. And that may, precede any changes in any testing that we can do or objective findings. So really important to take that into account. Another study looking at targeting HPA axis dysfunction in the early stages of neurodegeneration and how that can really be, a modification that you can use prior to clinical manifestations of the disease. So in other words, if you see changes in the cortisol awakening response on the cortisol curve in someone who has subjective memory complaints, you definitely want to take that into account, and you want to start treatment thereof because it may precede anything that you can see clinically. And we also know that the cortisol awakening response was associated with agnostic change to mild cognitive impairment. So in other words, the earlier you catch it, the better, but realize that it is also correlated with patients with mild cognitive decline. So in other words, in any patient with mild cognitive decline, we should be doing cortisol awakening response as well as cortisol testing on those patients. Now, we've also had quite a few studies looking at what about sleep? And if someone wakes several times during the night, for example, would that make a difference? And would that affect the cortisol awakening response? And the fact is that not necessarily. What does disturb sleep through, let's say, your forced nocturnal awakenings, has very little effect upon the cortisol awakening response in patients who are otherwise healthy. However, shift work does cause severe modifications in the cortisol awakening response, as well as in the diurnal cortisol curve, as we know. Now, this is a study looking at patients with glycemia, changes in glycemia, insulin resistance, and really looking at, can you also see changes in the cortisol awakening response in the cortisol curve? And yes, the fact is that anyone who has sort of metabolic syndrome or insulin resistance, we should be looking at this because we know that there is HPA axis dysfunction, and that is correlated with a higher changes in hemoglobin A1C. So for example, in patients who are insulin resistant, pre-diabetic or diabetics, the higher the hemoglobin A1C, the more you see HPA axis dysfunction. And the reverse is true. So in patients who are non-diabetic, you see better HPA axis function with lower insulin resistance. So in other words, with the more insulin sensitive someone is, the less changes you see in the HPA axis, or the less HPA axis dysfunction. Now, we know that depression is associated with changes in the HPA axis, and we know that those are usually divided into hypercortisolemic depressions and hypo. And your hypercortisolemic type of depression is more of your melancholic depression, whereas your hypocortisol depression is your atypical depression. And that's extremely important to look at because the #1 prescription drug for depression in this country are the SSRIs. And SSRIs work not just on serotonin, but they work especially on cortisol. And they work to lower cortisol. And that has been studied multiple times, and is always found to be true with all the different SSRIs. So I think it's one of the reasons why we sometimes see a lot of treatment failures with SSRIs. So anybody who has a mood disorder, we should be looking at the cortisol awakening response and the cortisol curve, and realize that if it's a hypercortisolemic depression, that's an area where an SSRI may help if their patients are on it already. Of course, we're going to be doing much more than that because we know that we need to treat the HPA axis differently, and I'll get to that at the end of my talk. But also, if someone comes to you an SSRI with a depression on an SSRI with a failure to have any effect from the SSRI, consider that they may have had a hypocortisolemic depression. And so you can look at. Now, the only thing is when you are seeing someone who's already been on an SSRI and you're trying to assess that, and you do the cortisol awakening response and the cortisol curve and it's low, you have to then work back with a history to figure out, is it low because they were started on SSRI, or were they always low? But that's where the history becomes really important, and you can go back and test it. Now, the cortisol awakening response has been tested in all different types of depressions as well as mood disorders. And what they found that there's also an association with depression, and especially in those patients who have a tendency to sort of internalize their problems, that you might see changes in the cortisol awakening response before you actually see some other physiological changes. Now, this is another study, again, still on depression. I wanted to give you several ones so that if you want to discuss this with your colleagues or you want to just look it up and sort of convince yourself how important this is to adopt to your practice, and you have some studies that you can look at. And this is looking at in major depressive disorder, and again, that there's a common finding of elevated morning cortisol and a reduced cortisol awakening response. So you sometimes see the changes in the cortisol awakening response before you see it throughout. But remember, then again, depression can be further divided into melancholic depression, your hypercortisolemic depression, and your atypical depression, which is your hypocortisol depression. Now, this was really looking at looking at the cortisol awakening response and reviewing it with respect to sleep disorders. And should we be looking at the cortisol awakening response and trying to figure out, by changes in it, if indeed someone does or does not have a sleep disorder? And what they found is that the information, the literature is too confounding. So there's some that show yes, there is a correlation, and there's some that show no. So for now, we can't necessarily use it to assess whether or not someone has a sleep disorder. You can look at the literature and compare what you have, but really there's not sufficient consistency in the literature. It's a complicated subject, and there's not enough to say, yes, you can absolutely see changes. More to come on this, because there's ongoing research. Now, I particularly like this study because I always look at to see, okay, so I can use these tests to diagnose, but how do I then apply this in a clinical setting? How do I use it to make a difference in my patient's life? How can it then be further applied? Because it's one thing to have the knowledge, but it's another thing to then, what do you do with that knowledge? And how do we use it to improve patient outcomes and to really help our patients? So this was a retreat with yoga and mindfulness, and it was a 3-month yoga and meditation retreat, and it was amazing because it was very, very positive results. Found not only do you have decreases in self-reported changes in anxiety and depression, but you also had an increase in mindfulness, and they actually saw changes in the cortisol awakening response as well as brain-derived neurotrophic factor and lots of different inflammatory factors that they were looking at. So pretty amazing. Which then brings me to treatment. How do we take all of this information and how do we apply it to patients? And how can we make a difference, in our patients' lives? So let's take another deep breath. I know it's only been about 10-15 minutes, but again, let's just try and shift left brain, right brain, so we can retain all this information. So another one of my beautiful sites. This island is known for being green, all year round, and having, just the most gorgeous views. It's a lot like the Nepali coast and the Hawaiian Islands. So let's go back to what do I think are the causes. And I know this is a long list, but that's how our patients are. Basically, our patients are usually complicated, and I think it's important that we consider everything when we're looking at that list and really try and figure it out. Now, you could break it down even further if you wanted to, and you could think of, okay, is it stress? Is it toxicity? Is it infection? Is it allergies and sensitivities? Or is it a deficiency, right? You can break it down even further if you wanted to, but really to be thorough and to be complete and to try and figure out exactly what has contributed to the state that our patients are at, I think it's really important that we keep this list and we keep everything in mind. We keep it in mind and try and use it to see where do our patients lie, what applies mostly for our patients. Realizing too that sometimes you may have more than one thing, right? You may have someone who has a single nucleotide polymorphism in their methylation pathway, for example, and they had a toxic exposure, which makes that even more difficult for them to then detoxify. But they may also have a sensitivity to gluten, for example, that has caused inflammation. So you may have 2 or 3 things going on. But to me, by having this list and really repeatedly going back to it, it helps you organize and figure out, okay, what areas am I at? Keeping in mind that they may more than one, because it's also going to then help you on your approach and your treatment. You know, what are we going to do about it? So my treatment for adrenal dysfunction is what I call either the 3 tiers or the 4 tiers. And I use this with every patient, but I also apply it to them and what do they want to do and what do they feel comfortable with. So to me, the first tier, that's foundation, is key, is lifestyle modification. Because if someone has HPA axis dysfunction, we need to try and get them sort of off of those neural circuits. We need to try and do something that's going to create new neuronal pathways. And we know that there's quite a few things that can do that, but it starts with lifestyle modification. That is key. And then we add sort of different things to that, right? Whether we teach our patients how to meditate, you know, how to do mindfulness exercises, if you will. But we also exercise in the sense that, you know, there's some action that you're doing, not necessarily a physical exercise. Although physical exercise is also extremely important, and you're going to adjust it for the stage of adrenal dysfunction that the patient is on, right? But the lifestyle modification is really key. And we know that there are particularly certain things that can really help that HPA axis dysfunction. Yoga, meditation, Tai Chi, Qigong, mindfulness, just gratitude in general, being grateful for what positive things there are in life, or, you know, teaching our patients how to find those. You can use heart rate variability, which works great. You know, it measures the beat-to-beat variability between each beat of our heart. And we know that the heart should be under the parasympathetic nervous system, but the more stressed we become, it gets more and more under the sympathetic. And so using heart rate variability, you can measure where someone's at, and then you can increase their heart rate variability, and that's been correlated with changes in the HPA axis. And in many cases, you know, you can actually measure and then start a treatment like diaphragmatic breathing, for example, and continue to measure their heart rate variability, and you see that there's an improvement. And then nutrition. Nutrition is also key. It's our foundation. Wholesome, fresh, whole, unprocessed, organic, colorful, eating like the rainbow, like my friend Diana Minnick says, that is high on the phytonutrient spectrum. But you want to make sure that you're eating 10 to 12 servings of vegetables and fruit per day, that it's fermented. And I particularly like fermenting with only specific strains like Lactobacillus plantarum, for example, or a combination that contains Lactobacillus plantarum, because we know that that's been associated with, you know, your gut-brain connection, and not just changes in your gut, but changes in your brain as well. And also that Lactobacillus plantarum has been shown to reverse insulin resistance by working with a gut microbiome. But you also want it to be high in fiber, lots of nuts and seeds, and I usually want 35 grams of fiber per day. And then you're going to also do, you know, your more targeted dietary interventions. So like your elimination diet, for example. I do an elimination diet on all my patients. And you're going to tell them which type of sort of a dietary plan you want them on. But you also want to look at, you know, what is going on with their mind, body, spirit equilibrium, and address that as well. So to me, that's foundation. That's a number one. Tier number two is when we then add our supplements or nutraceuticals who are going to help our patients. And this would be particularly your B vitamins. So a vitamin that's higher in B1, B2, B6, B12, and B9, so that it is the active form. So instead of folate, we're using 5-methylfolate, for example. And B12, we're maybe using either the hydroxy or the methyl B12. And if someone's gut is not working very well, you may choose the sublingual route or the IM route before, you know, your gut is fully functional. And of course you want it to be high in zinc, omega-3s, and magnesium, and high in vitamin C, because we know that vitamin C just pours out of the adrenal cortex when someone is stressed. So you want at least 2,000 milligrams of vitamin C per day. So that's your tier number 2, your supplements and nutraceuticals. And so you may do your foundation, you can add your supplements, and remember that pantothenic acid, or B5, enters the steroidogenic pathway, sort of where pregnenolone would. So in someone who doesn't want hormonal replacement, you can use pantothenic acid, for example, as long as you're also supplementing with the other B vitamins, your magnesium, your zinc, and your omega-3s. So that's tier number 2. Tier number 3 is my botanicals, my adaptogens, which I find that they're invaluable. You cannot, in my mind, really address the HPA axis without using adaptogens. And I really like adjusting adaptogens per stage. So you can do those for stage 1, stage 2, stage 3, and depending where the patient is on that. If you find that too difficult, to figure out where on that continuum the patient is, you can predominantly do your ask, is this a hypo or a hypercortisol state, and use your adaptogens, adjusting accordingly to that. And then my tier number 4 is hormonal replacement. And for me, hormonal replacement consists of 2 major hormones, and that's pregnenolone and DHEA. I don't use cortisol. I don't find that I need it when I'm doing the other 3 tiers. The only exceptions would be someone with severe adrenal dysfunction who's stage 3 and maybe is chronic fatigue or fibromyalgia and can't even get up, out of bed, so to speak. You might give them, 5 milligrams of cortisol or Cortef in the morning to try and get them up. But I have not had to do that in years. I'd say for at least 10 years. Because when we're working with everything else and we're doing that foundation piece and we're trying to figure out what the triggers are, usually that's not needed, although it is possible. But remember, when you're putting someone on Cortef, you're just a Band-Aid. You're just sort of tying them over until you fix the underlying issues. So really, pregnenolone and DHEA has been major importance to me and in my practice. And we have lots of studies on DHEA showing how it can sort of reset the HPA axis. So those 2, and I've used very low doses, but those 2 have been invaluable. So for example, with DHEA, I'll just do 5 milligrams sublingual twice a day for women. For men, usually twice that amount. And with pregnenolone, 5 to 10 milligrams twice a day, again sublingual, higher doses in men. But I also measure, and I measure the DHEA in the saliva as well as DHEAS, and pregnenolone as well in the serum. So now let's just take a look at how I might then apply this to a case. So this is a 54-year-old patient of mine who comes in with progressive fatigue and low motivation. He's having some difficulty waking up and sort of getting going in the morning. He has his own very successful business, works really long hours, and he's really lacking in his exercise in the last couple years, except for walking. The main thing he complains is he's really finding like he cannot handle stressful situations like he used to, and he doesn't recover from stress as well as he used to. And also his memory is not as sharp, and especially when trying to do business deals. And so things that he would normally could multitask pretty well for a male, he's finding that he can't do now. Now, with past medical history, I only put the pertinent positives. He had some low back pain that was resolved with physical therapy. He's on no prescription medications. Now, this is what his morning cortisol looks like. So you see that the cortisol awakening response is 15% of expected, right? So he's lost the cortisol awakening response. If you just looked at the cortisol curve, he's low normal, especially in the morning. So you know that something is happening because the body is starting to sort of lose that early, highest level cortisol. But to me, the most sort of I always call it so my awe-provoking or my anxiety-provoking point is that for me is that he's lost his cortisol awakening response. So we know that we need to act quickly and try and figure out what's going on with him. So the number one thing is to try and go and figure out what has happened to him thus far. So what was the trigger, or is there more than one? And so that's the main thing that I did initially. So I put him on an elimination diet, and really looking at his history, he'd had a few toxic exposures, some over the years, but particularly right before this happened. So I thought that was a major thing with him. But we also wanted to look at all the other hormones and see if there's any changes in those, because some of his complaints, for example, are consistent with problems with thyroid, and so on. So you want to make sure you're also looking at the other hormones. So my initial treatment with him, on my initial visit, when I ordered all his labs, but didn't have necessarily his labs back yet, and then adjusted him according to his labs, or I started him on the elimination diet when I ordered the adrenal testing, and had to make sure that he was eating 10 to 12 servings of vegetables and fruit and 35 grams of fiber, and then zinc and selenium, for his foods, because I was suspecting there might be also a thyroid problem. And then, of course, when we got the labs back, then we adjust those. Put him on the nutraceutical specifically for what's going on with his HPA axis. That he was on a multivitamin. I adjusted that and made sure he had a B complex, which had all the B vitamins that are especially important for the adrenals. Vitamin C, I gave him methyl B12, and I started him on IM because his level was low, and also glutathione and CoQ10 support because I was really trying to work on his detoxification pathways. And for his lifestyle modification, I had him start heart rate variability, do yoga because he had done yoga before and had stopped, and really just time for himself, to spend with himself and see, where does he want to go, with his life, what does he want to do, or just as I say, just time to ponder. And we discussed his exercise and also spiritual practice, which he had in the past and was not currently active. This is his repeat salivary adrenal profile. Oh, by the way, one thing I forgot to mention on here is this was my initial treatment. I forgot to add that once I had that results back, I then started also him on DHEA. His pregnenolone was 13, so I also started him on pregnenolone. And this is what his initial study was. And then I forgot to add here what I did because we did do hormone replacement and also adaptogens. And then this is his salivary profile 3 months later. Now, one of the reasons why I chose this case is because I always think it would be really nice when you find a dysfunction, adrenal dysfunction, and you start your treatment, and then the adrenals just sort of, gradually come back. You reset the HPA axis, and things sort of come back gradually. But that's not usually what you see. What you'll see is sort of it kind of gets jump-started, so to speak. So you'll have an elevated cortisol and a cortisol awakening response, let's say. And then, with time and you adjusting your adaptogens and your lifestyle modifications and their diet, then it comes down to normal. So this is what we saw at the 3 months, where he was still having some elevated cortisol throughout the day, but the cortisol working response was better. So in someone like this, then what would be your next step? What would you do following this? Well, what I did is I then switched his adaptogens, because initially I was doing more adaptogens to help his cortisol because it was low, and then we switched them. So I switched them from those more hypocortisol type of adaptogens, things like cordyceps, and you could even use Panax ginseng and licorice. But remember, with licorice, you want to monitor their blood pressure, and I like using licorice together with Romania and ashwagandha because it really sort of helps, the offset, the effects on the blood pressure. And then I switched them to more of the adaptogens you use with hypercortisolemic, things like jujube fruit and schizandra and Romania, for example. And then 8 months later, his DHEA was within normal limits, and so was his cortisol curve. Now, it's important that when something like we have a patient that's pretty complex and there's several things going on, that we're always also looking for the underlying root causes, which in him was some toxins, which took quite a while because we had to really work on those detoxification pathways. But the important thing is that the cortisol awakening response can be an earlier marker of the adrenal dysfunction. So I really hope that I've convinced you that it's something that's easily adapted into your adrenal cortex profile, but yet something that's going to give you a lot of information and really help us adopt it in the clinical setting and help our patients. And I hope I didn't speak too fast and that I can help you with some questions.
Thank you. That was amazing, as always. We do have quite a few questions, clinical questions that we did receive during your presentation. The first one is regarding, you mentioned using different adaptogens or botanicals depending on the stage of adrenal exhaustion that the patient is on. Can you please give 1 to 2 examples of which botanicals you may use in different stages?
So it's perfect, yes. Actually, I kind of mentioned that at the last minute here. But so in stage 1, I use things like jujube fruit, Romania, schizandra, whereas in stage 3, let's say, for example, or when the cortisol is low and the DHEA is low, for stage 3, I like using You can use licorice and ashwagandha and Romania cordyceps. You can use Panax ginseng. In stage 2, I use a lot of rhodiola. You can use also some Panax and cordyceps if they're low, if they're late sort of stage 2. If they're early on stage 2, I use rhodiola and eleuthero, basically.
Thank you. And do you find that patients over time stop responding to adaptogens?
I find that you have to keep checking. I don't think it's so much that they'll stop responding. I think it's that the HPA axis can shift. And so you have to retest and see where they at. Just like with my patient, I initially gave him adaptogens for hypocortisol, but then the adrenals came back. And so I had to change my adaptogens and switch them to hyper. Or sometimes if they were having erratic, like in this case, I could have used rhodiola as well. So I think it's important for us to look at what's happening with the HPA axis, because there may be shifts and we may need to readjust our adaptogens.
Thank you. How long do you tend to keep patients on DHEA and or pregnenolone?
It depends. So pregnenolone is known as a hormone of memory. It needs to be 50 to maintain memory, and between 50 and 80, if you're really working with someone in dementia where you're really trying to create new memory, so to speak. So I will do it until I get to that level, whether 50 or between 50 and 80, and then I can stop. With DHEA, it depends on their problem. So in most cases, I'll get them to their level. If you're looking in the saliva, I usually like it sort of upper range of normal. If I'm looking at DHEAS in the serum, I usually like around 150. So once I get them into what I consider that what the levels would have been around age 35 to 40, then I'll back off and have them stop, unless they have an autoimmune condition. Because if they have an autoimmune condition, we have lots of studies showing, the need for higher levels. And even though I'm always worried about the downstream effects, those studies haven't really shown that there's a lot of downstream effects. In other words, even high-dose DHEA in someone with RA tends to stay as DHEA and not go downstream, but I always check it, make sure it's not being aromatized, all the way to estradiol or to testosterone. We know in women, DHEA tends to go more to testosterone, and in men to DHEA, and those are just because of the enzymes that are turned on. But I always retest and see, and I find that in most cases, I don't have to keep them on indefinitely unless they have an autoimmune condition.
With regards to retesting the cortisol curve as well as the CAR, what is your time frame?
So I usually retest about every 3 months. Sometimes it's every 4 months, depending on what I've been doing and how compliant the patient has been with the treatment.
And for our last question, you mentioned physical exercise and to adjust for the stage of adrenal exhaustion they are at. Could you please give some examples or elaborate just a little more?
Sure. So the studies have actually been really controversial in this area as well. And I think that's because they've looked at adrenal dysfunction, but maybe we haven't necessarily sort of divided into the 3 different groups or the 3 different stages. But what I find is, for example, if someone is an athlete or they're trying to run a marathon and they're in stage 3, I'm going to tell them we need to stop, that we need to tone it down and do more stretching, more movement, things that are going to help lymph movement and lymphatic drainage, and they're going to get some some exercise, but not overdo it, because you don't want to tax the adrenals even further. Whereas if someone is in hypercortisol and they maybe not be exercising, I may want to add some exercise because it's going to increase circulation and it may actually even help lower the cortisol. So I like adjusting it based on where they're at and to see, because sometimes, patients are so used to, exercising hard that even if now all of a sudden they have adrenal dysfunction, they want to continue, and it may not always be the best for them at that particular time. So we just need to sort of adjust it based on what the CAR is, what their adrenal graph is throughout the day, and what's going on with them, so that we are not sort of depleting them any further, but we're helping them actually recover and reset the HPA axis.
Okay, so due to time constraints, we'll end our question and answer period there. For additional education materials, we'd like to encourage you to visit our website, www.gdx.net.
Thanks so much, you guys. Have a great day.
So just as a reminder, on this website, you're going to find some sample reports, kit instructions, and more information for each of our profiles. And after you take advantage of the materials found on our website, you can contact client services with additional questions. And you'll see on the screen contact number for both US and UK customer service. Additionally, you can always call client services if you need assistance setting up a MyGDX account. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. Finally, we'd like to encourage you to register for our upcoming webinar on www.gdx.net. Next month, we'll have Dr. Michelle Maddox presenting case studies on HPA axis in the gut. Thanks again, Dr. Trindade, for a great presentation.